vaccines. It was quite a moment for Arizona, and we really thank you for immunizing yourself, because we know that it really does go a long way in making the rest of the community feel confident in our decisions to vaccinate. So thank you for that. And as happy as we are to see these vaccines getting into arms, we are equally or more so saddened that COVID-19 continues to devastate families and devastate communities, many of whom are marginalized communities, communities of color, essential workers who don't have the opportunity to work from home. And you know that because they're your colleagues and they're your patients. In Arizona, as of today, we have 743,232 cases of COVID-19 confirmed and probable. And nationally, we have 25,301,166 total cases. In Arizona, there are 12,819 people who have died of COVID-19. And nationally, there's 423,519 people who have died of COVID-19. And I think we'll just pause there for a minute. We know that in our communities in Arizona, 12,000 families are mourning, and we've all been through that mourning. You know, we know that this is going to be years where those families are readjusting, and wish that there was more we could do to help, but we all know there's not. Grief's a process and it's a personal one, but we do hope that the vaccine provides hope, and I think it's that spirit of hope that we all gather today to talk about things that we can actually do to help reverse this trend. But we want to make sure that we remember that these are real people and real lives. So in our spirit of hope today, we are going to hear about the vaccine distribution plan in Arizona, our state plan. This is something that you asked for, and we hope to give you answers. We're sure we won't be able to give you lots of answers, but ask the questions and we'll try and find them. We are also really honored to have Dr. Edmund Baker here with us tonight from Equality Health. Dr. Baker is going to talk with us about the role of trust in communities and in your patients, the role of the physician in advocating for COVID vaccine, and kind of what you're up against from a community perspective as you try to partner with families in making these in making the best decision for them. And then we also want to just create a space for you to help each other on what are you hearing about COVID? What are the concerns that your patients are sharing, and what are you finding that's effective, both in helping your patients navigate the system to access a COVID vaccine if they are one of those eligible groups, and just in their process of making that decision. So some people who are not going to have access to a vaccine for a long time, maybe they're in the 1C general population group, are still starting to make that decision and gather information. We're going to jump in and start with our state distribution plan. I'm going to introduce Jennifer Tinney with TAPI, the Arizona Partnership for Immunizations, and TAPI is our host today. We are your state vaccine coalition. Our mission is to foster community wellness and advocate for good public policy and best immunization practices. You all know us, you are our partners, but we have about 400 coalition members in our coalition. So we represent all sorts of sectors that have something to do with immunization. So she's going to talk about distribution plans. Feel free to interrupt her and unmute yourself and ask questions. We can be pretty informal tonight because as much as we know that your confidence in recommending the vaccine makes a huge difference, at TAPI, we're systems people. That public policy thing is part of our mission. And we know that physicians and nurses and healthcare providers, your participation in the design of our vaccine delivery system is what really keeps our coverage rates high. So please feel free to ask whatever questions you want to ask and interrupt her. And if you chat them in, I'll ask them for you. So, and Jen, I'm going to stop sharing my screen and you can take it away on your slides.
Okay, thank you. Let's see. Now comes the technical part, right? How's it working?
Two thumbs up.
Seeing everything?
Yep, we see you. Well, we see you.
Awesome. I've got 3 screens going here, so I wasn't sure where your 2 thumbs were, but I found them. So tonight, I'm just going to go over a little bit about the vaccine distribution that's happening in Arizona, and also just a few key points of, typical questions that we're getting day to day now, because I know it's confusing. It's confusing for all of us who are listening day to day. So I thought first I would go over a little bit about how vaccine distribution happens in the state of Arizona. So first, the CDC sends ADHS the number of doses that have been allocated for the state. ADHS then kind of looks at the population of the state and divides that by county based on the population. So then the county knows which partners that it's working with, and those of you who are working with high-risk patients and looking at your capacity, they begin to allocate doses down to the providers and the clinics that are happening in the community. ADHS then links those number of doses that have been allocated to you all in ACES to your account. And then you accept those doses into ACES, and then the CDC ships it to you. So all of this data information is kind of going back and forth. Once you administer a dose, then you report that information into ACES with the patient record. It takes it off of the inventory. It tells that, it gives that new inventory piece to the CDC, and then they let ADHS know how many their allocated doses they're going to get for the next week based on what's been given, what's already been allocated, and the population per state. So all of those systems have to talk to each other at some level, whether it's your EHR or the state's vaccine management system, all have to talk to ACES. ACES has to talk to the CDC. CDC has to talk to McKesson and the manufacturers so that everything gets sent to you all and the cycle continues to go. Needless to say, there's 1,000 places where glitches can happen that makes this even more confusing as we get into things. But as of right now, there have been over 500,000 doses given to Arizonans. We have 906,000 doses total for the state that are being shipped right now or have already been administered, have already been here. But that's how much we've had as of yesterday. And I know some of those doses are still being shipped in. There are 400 provider sites that have received vaccines so far, COVID vaccines. Those are the health departments, which are doing those big pod and community clinics with some of their partners. The hospital systems, which are a lot of the partners working on those pods. The FQHCs began to receive some for their staff and for their patients over 75 in those high-risk communities that don't have access to healthcare. Those are the medically underserved areas. Pharmacies have received them, and pharmacies have 2 ways to receive vaccines. They signed up with the CDC to be part of a national distribution to do long-term care sites and later for some of the retail clinics. So those pharmacies get their allocation directly from CDC and they bypass that ADHS to county allocation. But however, the counties can decide to work with some pharmacies in their community and allocate some of our local doses to those pharmacies. So the ones that signed up for the national CDC program were usually like Walgreens, CVS, those big chain pharmacies. When looking at it, I think some of the counties have decided that, Fry's, Safeway, Albertsons, the grocery store-based pharmacies have a lot of reach into the small rural communities. So they've allocated some of those doses to the pharmacies in those locations for over 75. So the long-term care facilities, we have about 2,000 in Arizona. Those are the ones that the chain pharmacies are trying to get into to vaccinate. They've done, you know, a number of them, but it does take a while to get through those. They're time intense. They go 3 times to those locations: first dose, second dose, and then cleanup. And then, you know, you've got to work with the patients, you have to work with the staff at those sites, and a lot of times the families of the patients. So that does take quite a while. So they're still trying to get through some of those. I know, I'm sure some of you have heard from patients that, you know, my mom, dad that's in a care facility hasn't gotten their vaccine yet. They are getting there and they're working their way through it. So if you have patients who are trying to figure out a vaccine, you know, it's clear as mud, of course, like all things vaccines, but we have a couple of ways to do that. So first we have the state-based patient portal. It's a registration system, and it's also referred to as a vaccine management system. So the state decided to work with all the counties, and they made this system where people can go in and they can sign up for an appointment. And then on the back end, the partners who are working in it can log in and tell them which patients got what doses and how. And it's basically a big registration system. So the links for that are there. It's got a community-facing portal and then a back end for the clinicians. On the other side of the screen that's got the dark background, this is a link to the ADHS website that lists all the locations in the state that have vaccine. So some of those private partners, for instance, I have the example of Canyonlands up here. When you click on one of the little pins, it'll pull up that specific site location information. This one is for Canyonlands. When you click on registration website, you go to Canyonlands registration. So I know a lot of times in the media, they're listing this pod site registration site, this main one, but a whole lot of other providers are listed on this other link. So this is a way to help some of your patients that are really having a hard time getting into the clinics, is to use that other portal.
Jennifer, I'm so sorry.
Yeah.
Jennifer, I'm so sorry to interrupt. This is Dr. Maritza Rizarri, and we're talking about patients. I'm a pediatrician, so I'm mostly concerned about my staff, for example, because we care for the kids at all times. Just yesterday, I had one that they just said, oh, by the way, we had COVID in the house, but it's been 10 days, we think. Okay, so I'm concerned about my staff, and they have gotten themselves on the into the website, and they say that there's no availability on the patient registration, azhealth.gov, find vaccine. Does the fact that Pfizer is going to be out for 2 weeks has something to do with this?
That Pfizer is going to be out for 2 weeks?
Yes, they're going to have, they're going to lapse for 2 weeks, and then they're going to come back with more vaccines. But that's what I understood, that they are not, they're holding off on production for 2 weeks. Apparently they need to restock or something. And I know that the Janssen is going to be available in March, but I'm concerned about staff members that want to schedule their vaccines, right, like as soon as possible.
Are they, Dr. Rizarri, are they looking for first dose or second dose?
First.
For first dose?
Wow.
Yeah.
So I definitely try this other link and go directly to the county. What county is your practice in? Is it Maricopa?
Maricopa County, Phoenix.
Yeah, Maricopa has a list of locations on their website. You can get to it through the link that's got the black background. Okay. So you can get to it through there, and they have pods set up that are prioritized, especially for healthcare workers. You know, we certainly want to make sure that they were done first, and they need to get in quickly. So that azhealth.gov, find a vaccine, that's where everybody's trying to log into. So let's get them over to that other link, and then we'll send you some, additional direct links to it afterwards as well, because we definitely want to make sure your staff is covered.
Absolutely, I appreciate that, thanks.
I wonder
and I know there's
just while we have folks on since we have so many docs on the line, can you do, if you kind of hovered where it says participants and then click there, I think that's where you can raise your hand, right? Maybe Nicolene or Laura, can you tell me how to raise hands?
You're so right, Rebecca. I'm sorry. Hillbilly here.
Well, or maybe just chat. Maybe just chat in. If you also have staff that's waiting for their first or second dose, can you just chat that in for us, and your county, and that'll be helpful. We'll see if we can follow up with any resources.
Thank you.
Oh yeah, so everybody, feel free to jump in, anyone, because we know this is confusing. We want to answer the questions that you have right now the best that we can. So jump in with your comments, but if you can put in the chat how many, if all of your staff is covered. So yeah, but jump in and interrupt me anytime. No, it's no hillbilly. It's we're all trying to figure it out now as we go.
Thank you.
And as far as the Pfizer delay, I know that there's a resetting that's happening right now with Pfizer because they're reallocating the number of doses. They come in the 10 dose and the 5 dose vial with Moderna as well, but there's that additional dose that you can get out of it most of the time. So because of that additional dose, they're resetting their inventory and their projections of what they're going to hit because of those extra doses. So that, I don't know if they're having a manufacturing or a shortage delay of the vials, and they're going to add that into that restructuring, but we should have enough vaccine to do, certainly healthcare workers should be prioritized with what we've got, and that we still have some coming in this week. But on this registration system, which is confusing everyone, it's referred to as VMS very often, is the shorthand that you guys are hearing and notices and alerts and stuff like that. It's the vaccine management system. So this is that system that ADHS created. That's a statewide system. So for those of you or clinics that don't use a traditional EMR and don't have your own registration system, you can log in and you can get a login and use this as an appointment setter and a management system for the vaccines that you give. And then it automatically reports that information to ACES, and it sends all of that through to the CDC, so we have all of those allocation pieces done, and then you can pull out reports from that at the other end. It's optional. You don't have to use it. It's entirely up to you. But if you need something, it's available. It's also the main place that they're sending patients to register for a vaccine through this patient portal, and it's getting very confusing. So they actually have some instructions that are set up right here, a patient registration guide, how to register through this portal. Some of the tips are to keep refreshing that page, pick different dates, keep going. And then if they still can't get through, there's a helpline set up here. But I do suggest now, especially with healthcare workers and those that are over 75, use that other link and go directly to your county to find out how we can get those patients prioritized in. So this is what you hear most often, is this referring to the stadium clinic. It is run by the state. This is through ADHS and the governor's office and some partnerships. It's open to all Arizonans. So even though it's located in Maricopa County, it's not limited to Maricopa County residents. So anyone statewide can register for it. This is the location that is 65 plus. Most other locations are not, because we still don't have enough vaccine, and we're not going to have enough vaccine for a while. But this one went ahead and went to 65 plus because of the pressure that was happening nationally, and many other places going to 65 plus as well. So this is just kind of a listing of the tier groups that we have, and Rebecca's going to go into this in a little bit more detail. But the stadium site is one of the only sites that is doing 65 plus. We have a couple of small counties that are getting ready to move into that. Everyone else is still on Tier 1A and Tier 1B and still working their way through that. So this is what it looks like by county, by doses administered in the current priority groups. These are slightly old numbers because if it's gone for more than 12 hours, your numbers are old in COVID. So these are a little bit behind, but you can get a feel for how many doses have been administered in each county, and then what priority groups that they're in right now, which is still 1A and 1B. Most of them have not gone to 1C yet. So this just kind of illustrates the tough decisions that have to be made. So this is an example of a county. It's a smaller county that has 1,000 healthcare workers, 2,000 border patrol and police, and 3,200 that are over age 75. So they need over 6,000 vaccines just to get through Tier 1A and the first line of Tier 1B. And so far they've been allocated 3,300 doses. So you can see that they don't have the inventory yet to move down to those other ages, or to begin to bring in other partners, or to get vaccine to their private practices to be able to vaccinate their patients. They just haven't had the vaccine. That's for the entire county. It's a small county, but I think looking at those small numbers, it shows you what it looks like. Number of doses to number of patients that we have in the counties, we're just not anywhere near that yet, where we'd like to be. So, you know, the next steps for vaccine allocation, they plan to, as soon as we get more doses and as more doses come in, the next step will be to try to get vaccine out to as many of the private providers, because you're the ones that have relationships with your patients. You know who are high risk, who you need to prioritize and get in, and that's the ultimate goal for public health, is to get vaccine to the private partners, because you guys do the heavy lift on this one. There just haven't been enough vaccines to step beyond those big central clinics that are doing healthcare workers, teachers now, and over 75. But for your older patients, really try to get them into some of the pharmacies that are beginning to open up, some of those smaller areas, because those big clinics can be difficult to manage. But for you all, continue to partner with your county health departments, reach out to them. You know, if you're waiting and you're ready, let them know, just so they kind of have you on the radar. Make sure that you have completed all of the onboarding and any training that's required through ADHS, and we'll have the links available for those as we go through. Make sure you've completed all of that, so that when we get more vaccine, they can just send it to you, you know, right away. Start planning for your employee clinics if you haven't gotten through all of those yet, and organizing patient lists by tier group. So, you know, kind of just think about, you know, how many patients do you have over 75? How many do you have that are high risk? You know, just think about those in terms of who are you going to prioritize first when you have a limited number of doses and you've got to pull in some patients. Once you get to that point and you're ready to bill for the administration fee, we've got some guides available for that, and I've got a few points to let you know about now, because I know this is coming up for some. So billing for COVID-19 vaccine, because it's federally supplied, the vaccine is free, so you all bill for the administration fee of the vaccine and not the vaccine. The good news is the governor put in an executive order that is an open networks, meaning if you don't have a contract with a health plan, you can still bill for a patient and they will reimburse you for the admin fee. This is for most plans that are regulated by the state of Arizona. So it's not going to apply to everyone, but so far all plans have agreed to pay for it. And that's really going to free up the gamble of, you know, giving the vaccine to patients that are not on your typical patient roster list. Medicare Part B, they've decided that it's going to go through Part B under roster billing primarily. You can do the 1500 form, but whichever way you go, you have to collect the Medicare or the Social Security number. You don't use the Advantage Health Plan number. That's been tripping up some of the clinics that are doing over 75 and collecting the Advantage number. Oh, did you have a question?
I think it was an inadvertent unmute. Yeah, or
got it.
Accidental unmute.
Medicaid Access has agreed to reimburse all qualified providers, including non-Medicaid providers. However, you have to be registered with Access. So even if you don't typically take Medicaid patients, go ahead and register with Access as a provider, and you can bill for Access patients as well. So this will allow you to do wider, broader community-based clinics if you choose to, and it'll allow you to do family members of some of your high-risk patients if they don't have a medical home as well. So uninsured, that all goes through HRSA, through the Optum. system. So enroll with Optum if you believe you're going to vaccinate uninsured patients. Because the bottom line here is there is no out-of-pocket for patients. You can't balance bill them, and you can't charge a cash fee. So you either bill private insurance, Medicare, Medicaid, or the Optum insurance plan that's set up through HRSA as part of a federal program. The CMS rates for this vaccine are $16.94 for the first dose and $28.39 for the second dose. They're incentivizing you to get that second dose in. Right now, some of the payments that we've heard coming in are ranging about 12 to 15 for the regional Arizona rate. We have some plans that are adjusting, you know, based on that kind of recommended scale. But that's just the first dose. The second dose is going to be much higher, and that's where it will probably make you whole on the 2 doses. Kind of think of it as a combined series.
Jennifer, will a private provider who does not contract with Medicaid or Medicare be able to bill for uninsured through Optum?
Technically, they would no. Yes and no. So what you need to do is register with Medicare and register with Medicaid if you don't typically take those 2 insurance plans. They have a fast track registration. They'll get you done within 24 hours. They just want to know who you are and where to send the payment. Okay. So they're essentially saying you're not a regular Medicare, Medicaid provider, but today you're going to give a COVID vaccine and we're going to go ahead and pay you. So register with all those systems if you don't typically bill them. Mm-hmm. Then if you get down to it, and if you have, for instance, self-insured plan, and they're not covering the vaccine for you because they continue to say you're out of network, you're not part of the state of Arizona, they don't fall under the executive order. So if they don't pay you, submit that to Optum, and they will pay you because it's considered uninsured or underinsured. If you're not paid for that dose, submit it to Optum. So I think those are the yes and no's.
Yeah.
But Medicare and Medicaid will pay you, even if you don't typically take patients in those categories. So we've developed a few materials to try to help, you know, as you're navigating through vaccine clinics. We have a postcard here that goes to a landing page, which has the EUAs in several languages for the patient information. It has what to expect after the shot, tells them how to download BSafe, so that you don't have to print out the 6-page EUA for every dose that you're giving, and then all of the BSafe information as well. You can give them a postcard. It takes them right to that website. The other piece that we have is a button. We did the I got my COVID vaccine into a button for your staff. So as they get their COVID vaccine, order the buttons, have them wear them on their lanyard or their jackets, because it's a way to create that confidence. If they've seen that you've gotten it, that your staff has gotten the vaccine, and you're healthy and well and happy and excited to see them after, you know, a year of quarantine, then it's going to prompt those conversations. So we have those available. We also have some websites available for provider resources, which we've got billing guides on there. We have standing orders, some sample, you know, checklists of things to be ready for, and all the links for how you onboard for vaccine and where you need to register for that. We also have a community-facing page if you want to direct some patients to there. And then we have this landing page of I got my COVID vaccine, which has all of those materials that they'll need as you're beginning to vaccinate. And then I'm just going to end with my happy story here. Keep talking about vaccines, because this is my dad who got his COVID vaccine. He's 77. He's a tough guy. He never gets sick, which is what he's been telling me for 20 years while I worked in vaccine, and he never got a shot. He refused a flu shot, refused pneumonia shot, refused his shingles shot. And this year, while waiting for COVID, he got his first flu shot, he got his pneumococcal, and he got his Shingrix, which he then had to plan carefully for when he was going to get his COVID vaccine 2 weeks later, and he got his COVID vaccine. So it works. 20 years, I have been nagging and hounding and begging, and he says, I'm healthy and I'm fine. I don't need it. And, you know, here he is. Miracles happen. You keep talking about vaccines long enough, they get them. And then that's it for me tonight.
Thanks, Jen. I know that we have a lot of FQHCs that logged on, so they all have doses now. So you're just starting to be able to give vaccines, but we know a lot of you haven't actually been able to give a vaccine yet because you haven't been allocated doses yet. So, but I want to pause and see if there's any other questions or comments or things around distribution that you want to talk about. And Jen, you can stop sharing your slides whenever you want so we can take it away. And just unmute yourself and ask or chat in if you guys have any questions.
Yeah, and feel free to jump in. I'll try to get the chat as well.
So I have another question.
Yeah.
What about medical students under clinical rotations? I have gotten these questions from them. And right now I have a couple of students with me and I would like to know, do they qualify or as health workers, or shall they go into a separate classification other than 1B?
So they qualify as 1A because they know that they're going to be around COVID positive patients. So
Excellent.
I did put a link in there knowing that you're in Maricopa County. There's a few pods that are doing healthcare workers and 75 plus only. So hopefully you can get an appointment that way.
Okay, thank you so much.
Our allocations for both doses are just one. They allocate just blanket, you get X thousand number of doses or 100 number of doses this week that you can give out. So it's up in our state, it's up to most of the delegation of vaccines is left to the county. So they determine their own plans about and have to, reserve doses if that's what they choose to do or not. So
most of them are getting second dose to the sites in a rolling order. So if you had your first dose really early on, they may not be right to your 3-week point if you got it late, but they're rolling in those second doses to those sites. Mm-hmm. And wherever you got your first dose, they'll be reaching out to you to get your second dose with a reminder as soon as they get that allocation.
Yeah. Anybody else have a question?
This is Barbara from Dignity Health's Immunization Outreach. I just had the question, does the state really know as far as the allocation, what we're looking at as far as general population? Are we talking, do you think, in April? And will these be multi-dose vials at this point, still working with like Moderna for our practices? Or are we looking at another vaccine maybe by then?
So it's hard to predict timelines of when we're going to get to general population, because we're dependent on the manufacturing and the allocation pieces, and we just don't have enough vaccine yet. We're slowly getting there. By April, yeah, I think it's safe to say we should be. We expect the Johnson & Johnson one in February and closely thereafter the AstraZeneca as well. And I believe they're all multi-dose vials, even though the Moderna and the Pfizer are the RNA, and both the Johnson & Johnson and the AstraZeneca, I can't remember the exact name for it, but we've been calling it a Trojan horse. They use an adenovirus with part of the COVID inside it, so that it comes in as like a virus that isn't going to make you sick, and then you mount an immune response to the coronavirus as well. So it's slightly different presentation, different type of vaccine, but it should be the same multi-dose vial presentation.
Yeah, they're both called viral vectors.
Ah, thank you. There's the official term.
Jennifer only plays a vaccine scientist on TV. Yeah. Exactly.
Yeah. I kind of half listen to my husband sometimes, and I'm like, wait, what? Yeah.
One of the problems I see is that with the multi-dose vials, how are we going to do those clinics, considering, for example, the Moderna, once it's open, you have 6 hours to use it. So how has there been a plan to develop, how are we going to be able to use those last end of the clinic doses and not be wasting a lot of our vaccine?
We've heard from a lot of sites that have developed plans where they kind of have a flexible wait list. So they know who's next on the list or who's coming up. They just keep one handy and they kind of go down the list until they get to the first, you know, say 4 people. If it's a Moderna dose and they've used one, they call until the next 4 people answer and say, you've got 30 minutes to get here to use this up. That's one good way to do it. It depends on where you're located as well. If you can start to develop some partnerships with practices that are around you that might have patients that are in the tier groups at that same time that you're closing up a clinic. People are getting kind of creative about it. And I think that the CDC is about to put out a guide of best practices for that. So we'll be sure to share it when they do.
Okay, so the individual providers, though, we won't be getting vaccine until it's really opened up to the general public. Is that correct?
We hope we'll get, we'll get enough allocation that you can start doing 75 and over. You can start doing your high risk patients. What were you saying, Rebecca? Do you know?
The same. I think that right now we need providers who can do thousands a day. I mean, because of the allocation problems, we need to, or allocation, you know, just the way the system is, we need to show the federal government we get it in, we get it out, give us more. And so I think that that's why the system is being built around these mass immunizers right now. I do think that there's been a lot of discussion about AstraZeneca, Johnson & Johnson being better fits for private offices. There's been a lot of discussion about Johnson & Johnson being a better fit for hard to reach populations that are going to be hard for us to find and get back in for the second dose, especially our homeless populations. So I think that just the where traditional primary care is going to come in is going to look very different. Where as you know, Jen and I talk with these mass immunizers, you know, a lot, and there's a lot of new people in our worlds now who aren't used to doing immunizations. And if there's anything that you can do to, especially, you know, the pediatric offices on the line, to forge partnerships with your geriatric providers, with your family docs who, you know, don't see Medicaid kids, probably don't use VFC, might not be familiar with ACEs, just to be able to kind of help prepare them so that when it's their turn, they don't waste doses because you're so good at not doing it. It's going to really help the community.
Yeah, that's a big one. It's the buddy system for vaccine. So yeah, you know, find your local pediatrician because they've got a vaccine coordinator expert somewhere in there that's used to managing ACEs and doses.
Right.
And how that works. And I can't tell you how many times a day, you know, these weeks, just explaining what ACEs is.
Yeah.
You know, these are providers who have never had to manage a federal vaccine before. And it's very, very different.
Mm-hmm. Yeah, it's frustrating. There's no clear answers on when, because we don't know that we don't have clear answers on the supply yet. You know, it is frustrating, but things change every day, very rapidly and sometimes for the better. So hopefully soon. Are there any consequences to clinics vaccinating those who try to walk in to get vaccinated with leftover doses? So that would be between whoever that vaccine provider is and the county that allocated those doses. That's who would make that decision, whether there would be a consequence or not. So the state would, whoever allocate, or if they were allocated doses by the state, it would be a problem with the state. But
and I know there's been some pretty sensational news stories around that these days, which is terrible. Ultimately, I think the bigger sin is letting that vaccine go to waste. We have a lot of arms and we don't have a lot of vaccine, but we need to make sure that not one of those vaccines lands in the trash. I think should be our ultimate goal.
Yeah. Anybody else have questions? if a patient gets, this is going to be a patient gets both Pfizer and Moderna, will a third dose be needed and which one? I think CDC is coming out, if they were going to come out with some more clear guidance on Pfizer Moderna stuff this week. Did they yet, Jennifer?
I might have seen some links earlier, but I think the consensus has been give the same brand. If you don't revaccinate. They may change their tune on that as we go because more evidence comes up, but so far don't revaccinate.
Because they're made, the mRNA vaccines have such a similar immune response, or?
Hopefully it's similar enough that it boosts that, you know, that you get that primer dose in the first one and then you get the immune response in the second. And I think they're still looking at that. So that could change. You know, we don't know very much yet about long-term immunity with these.
Right. Anything else? We wanted to make sure, oops, that's the wrong slide. We wanted to make sure, that's my to-do list. We've reviewed who's eligible for vaccines because we think that that's getting a little bit confusing county by county too. So remember, the counties are, the state has their prioritization list. So phase 1A, 1B is what we're in right now, and that's who they're vaccinating at the state pods. And we have the state farm here in Phoenix, but the governor has talked about opening new pods up in other parts of the state, which is fabulous. They have 65 and over. That's the big difference, right? Most of our counties are not including 65 and over in their phase 1B at this time. So if you have patients who are 65 and over, they do need to get themselves to a state pod. They can't go to most of your county pods. Since most of you live in Maricopa County, we thought we'd show the Maricopa County prioritization, and this one's, you know, so phase 1B is just a huge group of people. I mean, you're talking a lot of people, a good chunk of the population. So most of the counties are putting that into kind of two tiers. So these first three buckets under phase 1B, education and childcare, law enforcement, and over 75 adults, are kind of a first tier. And once we're through a good portion of those populations, then in Maricopa County, we will start moving towards adults living in congregate settings, adults over 65, and other essential workers. So now remember, all of this stuff, as everything COVID, is subject to change at any point in time. It may change by the time we log off today, but we are interested to find out from you, what are you doing, if anything, to reach these populations with information? We know most of you probably aren't administering vaccines yet, but we're curious, are you running reports already? Do you know how many people over 75 are in your patient panel? Are you screening patients at check-in or during the visit with their provider? Are you doing some media campaigns, emailing your patients about how to access the vaccine? What are you doing? And if you're clicking other, which I see a few people are, go ahead and chat those in so that we can share some ideas with each other. And we'll give you maybe 5 or 6 more seconds here. Dr. Baker is doing webinars. He is. With patients, you are? With real people?
Oh, yeah, absolutely. So I do families, I do organizations. A lot of organizations come to me, not just in Phoenix, but across the country. So there's some pretty well-attended webinars.
Oh, cool. So here's what most folks are doing. So it looks like most popular answer anyway was screening during the visit. So I guess just screening for age or employment and things like that. Wow, Ashley Wilkie said they got 1,000 vaccines done in their small town in Navajo County. That's amazing. And we know that those of you in rural distribution, as as Jen shared that example from one of our counties, that's something that TAPI's been thinking about as well and keeping an eye on. And we know that when COVID hits those small communities, in any community it hits, but we know how much it's been impacting you also. All right, well, as regardless of who's eligible, this is actually kind of stale data at this point. This was an October survey that was done, that Harris survey that we all heard about, and it said only about half the public said that they would receive a COVID vaccine. They were worried about side effects. Does it work? Is it safe? Is it going to cost me any money? And this was also what made us all start pushing physicians to talk about your own vaccine story, because this survey also showed that when a healthcare provider said, I got my shot, then people said, well, I want to get mine too. And I also, before we turn it over to Dr. Baker, want to talk about the CDC has this framework. This isn't a campaign, but rather a framework to think about how can physicians build confidence in their patients about vaccines. And it has three core points. The first is building trust. So how can physicians share accurate information that's based on science, but delivered in a way that builds trust in the vaccine and in the science, and with aligned messages with federal and state and local government and community partners. The second part of this framework is to empower healthcare professionals to get vaccinated and recommend vaccines. And the third is really closely related to that first component, and that is engaging communities and individuals in sustainable, equitable, and inclusive ways. So two-way communication that's built on trust. And we are starting at the ground level tonight, and we're excited for Dr. Baker to talk with us about that. And you can share your slides if you want, and maybe tell us a little about who you are too. And you're still on mute.
Yeah, I was just getting my screens up here. Let me get everything up and running. Good evening, everyone. I am really honored to be able to talk to you guys today. As everyone has said, this is a ever-changing environment, something that has not been like this in medicine for some time. So don't feel out of sorts if you just don't know the right things to say and when to say them. And if I'm saying anything today that's below you, that you know everything about, please just bear with me, because I'm pretty sure someone in the room needs to hear some of this. And feel free to stop me at any time, and we can go deeper into some of these core topics. My name is Edmund Baker. I'm trained as an obstetrician gynecologist. I'm currently a medical director at Equality Health, as well as an adjunct professor at Arizona State University, where I actually teach a course to doctoral students in health disparities and how to communicate with people that you are not necessarily like. Now, understand this is a full semester course, and I'm going to try to talk only briefly about some things, but please feel free to reach out to me and we can have further discussions over coffee. So as I will now continue, first let's just talk a little bit about trust. Just the basic definition of what trust is. It is that firm belief in the reliability, truth, ability to, or strength of someone. So be able to get that trust in someone. They have to really believe in you. They have to believe you are telling the truth. Those building blocks, when you have a trustful relationship with a patient, you are able to truly affect change in that patient's health. In a 2000 article, Stephen Person talked about trust as one of the central features of patient-physician relationships. And because of this dynamic nature of medicine that we are experiencing, especially in 2020, the uncertainty and rapid changes create fear in many patients. And patients are stopped coming to us, and they seek their trust or their information from things like Dr. Google, Facebook, and politicians. So the building blocks of trust, keeping in mind the doctor-patient relationship should be real and naturally formed, I will provide a quick dissection of this relationship. So the provider must start with good intentions. You know, the patient can tell when we're just punching the clock and just running in the room and trying to get out and get to the end of the day so we can go golfing. Patients could tell that. We must be empathetic, and we must be honest with a patient when we don't know, especially during COVID. I remember the first time I talked in public was in March of last year on TV. We did streaming on ABC, and people would call and ask questions, and just remember how much we actually knew about COVID back in March of last year. And here I am in the hot seat, and there's a lot of times I didn't know the answers, but what I did is I answered everything the best I could, and then provided communications through subsequent webinars, or even through our company helped publish different social media posts to answer some of the questions. So to get back with them, I had the accountability to make sure I did that. And we have to be competent. The patient has to feel that we're listening, but not just that we're listening, but that they are heard. Those are two different things, right? So that patient experience, when they leave out of there, they should truly feel that that was an experience where they were able to tell their concerns and we were able to help them with it. And again, we need to stay in the books and keep our expertise up as much as we can, but that's something we all know. For those that don't know, this is truly an us versus them. And the reason is there's been so much broken trust in the history of medicine. And I just want to talk about one of them, because there's many examples. Let's talk about Tuskegee for a moment. So the Tuskegee experiment started out as a 6-month study back in 1932, and the goal was to look at syphilis in the population. They started with 600 patients. There were about 301 people with latent syphilis, and there was 299 that had no infection whatsoever. Now, this study was not just a study by a small clinic. This was actually put on by the U.S. Public Health Service Organization. So this was a federally funded study. And how they got people to enroll, they said, hey, listen, we're going to give you free medical care. If you need treatment, we'll treat you. But what actually happened was there was a lot of placebo given, and there was a lot of unwarranted procedures done for syphilis patients. Now, if you're a provider, the first thing you wonder is what kind of procedures could you be doing? And that's exactly right. A lot of these were truly unwarranted. So it wasn't like this was a 6-month study. This did not stop until 1972. So all those years of untreated patients, and they allowed people who they knew were positive to continually infect other people in the community. So there's a lot of broken trust because of that. And then also there's implicit bias. Now, whenever I say that, especially in a group of providers like myself, a lot of people, they get that squeamish feeling because no one wants to talk about implicit bias because it feels like I'm pointing fingers at people. And I'm gonna tell you, I have implicit biases. Everyone I'm talking to has them. And they are unintended biases. And it usually comes out of these unconscious ideologies that you have. It could be from news. It could be from how you were taught. It comes from so many different ways, but this is unintended biases. So it's not that you're being malicious or being even malignant to patients. This is something that happens. So let's talk about a quick study Dr. Chapman did in 2013, where she actually looked at physicians and the implicit bias scale. And what she noted was doctors, even though they're educated, even though they're amongst some of the smartest, and this is not just doctors, this is nurse practitioners, this is PAs, this is all levels of healthcare providers, even though they're highly educated, they still carry implicit biases because they're human. Everyone on here is human. And it was noted that the perception of an interaction between white physicians and Black patients was affected by a physician's implicit bias, even if there was no explicit bias presented. And how it's often seen is patients often don't listen to those providers. They don't trust them. So they don't adhere to their therapy. They have reduced return for follow-up. Lack of trust is just huge amongst this patient population, and it all leads to disparity of care. Just talk about 2 other studies. So there's 2 studies one, that show Black patients in ERs, and of course we know, and all docs know that ER give less analgesia to Black patients than they do to white patients. That's been well studied. In another study, they show Hispanic patients were 7 times less likely to receive opioids in the emergency room. And in a follow-up study, see, this is the kicker right here. In the follow-up study, it was found that the physicians were able to accurately identify what the severity of pain was in those patients, yet still provided less analgesia to the Hispanic patients with severe pain. This is a known problem, and we have to identify this if we're going to do better by our patients. So let's really quickly talk about equality and equity. We're going to forget about the reality slide there. It's there for a bit of truth and a bit of humor. But equity is where we want to be. Equality, we give everybody the same thing. In other words, everybody's getting the vaccine. That's the same with everyone. But just giving everybody the vaccine may not be the answer, right? Because if I make it available to everyone and someone doesn't have transportation, someone doesn't have cost for whether it be cost for a bus fare or Uber ride, or it's too far to walk, it now becomes an unequitable situation. So we have to help with that. And some of the things we talked today about that were all about the equity of the delivery of this vaccine. Just want to talk about differences really quick. And some of the differences seem to be very obvious to us, like language cultures. But just remember, language can cause barriers, especially when you look at 72% of immigrants who believe they speak English either well or very well. But what's happening is they're not really understanding what's happening. You know, there's a lot of head shaking yes, or they just may not understand what you're talking about, because we as providers often talk well over their head. And we know that disparities are still noted amongst immigrants and minority populations because of social economic status, employment, legal status, and non-financial barriers such as language and limited English proficiency and limited health literacy proficiency. This all leads to decreased access of care. Just remember, just talking about Spanish, because say, oh, I speak Spanish. I'm a native Spanish speaker. I went down to Mexico. I learned Spanish. I talk Spanish with my patients. But remember, although Spanish is common throughout Latin America, one must understand how words, some phrases different depending on region, and additionally, not everyone in Mexico speaks Spanish, right? There's other languages. Actually, there's probably more than 60 languages down there, which some are like Yucatec Mayan and other languages where, people don't speak Spanish. So, we go in assuming a situation, and without dissecting it, patients just shake their head and they're really not understanding what's going on. So it's important to note that low health literacy is not language dependent. Culture is a prime mediator, and the US population that speaks another language has grown exponentially. So we have to do our best to try to be cross-culturally competent when talking to these different populations. So we talk about solutions. How do we do this? How do we get our patients who are difficult patients to understand, to trust us? How do we build this trust partnerships? First, we need to have partnerships with churches, community organizations, and nonprofits within our area. And the solutions all start from the grassroots, right? You need to be able to see everything through the lens of the patient. The voices of people are first heard at this level. And so in our community, the Black community, churches are primary. They're not supposed to be a place of politics, but we go to church and we hear all these things, and this is how we get our information. Before Facebook was around, it was the Black churches. So we need to improve the health disparities and build trust in communities. We need to find very creative ways to incorporate our practices with the churches, with the community organization, with the nonprofits, so that we can, as providers, help educate those people in those areas, as well as provide a level of access to those areas into our clinics so that we can take care of them. Because people who are doing this truly have the cultural competency that's needed for patients to build long-lasting, trustful relationships with. So I want to just give a little bit of statistics to put things in perspective. And this is all the way accurate up until January 5th. And this just looks at African Americans versus white. Now, I have other slides, but I just wanted to show this one because it can be kind of busy. And I'm just going to talk about Arizona. Arizona, even though the numbers don't show it on the website because those numbers are raw numbers, what you have to look at is the deaths per 100,000 as adjusted by age. And in Arizona, African Americans are twice as likely to die from COVID-19 as their white counterparts. This is true with Natives as well. They're actually worse here in Arizona, and also true with Hispanics. And if this is true, then we are not just, it's not just our job to talk about the COVID vaccine with these people, it's our obligation to cut through the distrust and to help educate in a way that they feel confident that this is the right thing to do. And again, we start with ourselves by being vaccinated. So I was also asking, please, this is open to everyone. I'm going to show the slide. And this is mostly talking about patient concerns. We're going to talk, I want people to give me situations that they may have run into, and we can talk about some of the ways that I've worked my way around it. Some of the things include people who are truly anti-vaxxers, or the technology happened too quick, or I don't want anything that alters my DNA, or uncertainty. So I'm gonna stop sharing here, and I'm gonna open this up to everyone so that you can ask questions about some of these difficult people and how, or offer solutions if you have them, how you've worked around it. It's a little quiet, so I'm just going to talk about the last event that I gave. I talked to a family, and it's not just a small family, it was well over 70 people on the call. And one of the things was this vaccine just happened too quickly. There's no way I'm gonna trust in it. And so what I gave them, and I have a lot more slides which really talk about how this worked out. This was one of the few times in history where people were able to produce a vaccine while they were still finishing the third phase of trials for the vaccine. And that was because of the amount of money that was afforded to a huge public health problem. I also talked to them about the two previous coronaviruses that came out. The first one being in the early 2000s, the original SARS virus, and then the second that came up around 2012, which is the MERS virus. The first one, they attempted a vaccine, but because it came and went so quickly, it was not economically feasible to do so, they didn't come up with a vaccine. When MERS came in 2012, 2013, they started working on a vaccine. And they actually were able to make it through phase 1 and partially way through phase 2. But again, it was finances that really stopped it, because even though it killed a lot of people, it was not worldwide spread, and people just didn't want to put the money into the vaccine. That's phase 1. That's understanding how to fight a coronavirus. The other part was this whole mRNA thing, right? Because now it's new and people don't know how to explain it. And I have slides that people need to see that today. I can run to my slides and actually really quickly show you what I tell patients. But in actuality, the mRNA we've been studying that for 10 years. We didn't have anything to try it on. We thought about cancer, we thought about other things. But when this solution came up, when this problem came up, it was a solution that was easily outfitted to fight the problem. And it's absolutely ingenious. So when I sit down with these patients and talk about it and show them diagrams on how this works, they begin to understand. They understand their DNA is not at all going to be infected, right? DNA is like in a vault. If you got a big old house, you're like, our mRNA comes through the front door, but they'll never find your bedroom because you got it behind a locked door. That's where the DNA is hidden. And you show them how it works and how your body responds to it and what's actually happening. And I've been really, really fortunate to be able to talk to groups across the country. And specifically, Michigan was one. I had a mayor of one of the small towns on the call, and she said, "There's no way I'm going to use this vaccine." And one of her constituents said, "Absolutely, I'm not going to touch it. This is crazy. They're trying to kill us. This is Tuskegee all over again." And I went through the entire talk with them, and the one point that I made to them that was really struck home with them was that at the time, this was back in December, there were 500,000 cases of COVID-19 in Michigan, with about 17,000 deaths. And I showed you the numbers. Michigan is terrible. It's almost 3-to-1 deaths, blacks over whites. And at that time, there was over 500,000 worldwide doses of Pfizer given, no deaths. A few, bad side effects, and, a few people learned that they shouldn't have taken it because they knew they had responses in previous vaccines. But with this vaccine being 95% effective, we're going to save lives, right? We're going to save lives. Those 17,000 people will be at dinner with you if they had access to this vaccine. And just thinking about anybody that grew up with polio or kids that you knew with polio or smallpox, we shouldn't even be talking about those things anymore. But because of the anti-vaxxers, some of that stuff is still creeping up, even in the United States. Those diseases decimated American population, or the worldwide populations. So no one even questioned whether we should be doing vaccines or not. I think this is this same situation now. And again, gaining trust in patients will help you get them to understand the importance and believe you, especially if you lead by example. So I'm going to pause now, and I really thank you for your time and attention in this matter.
We have a question coming in on the chat of what about when patients refer to doctors that are anti-COVID-19 vaccine?
That's a huge problem. I sit and I spend too much time watching YouTube, and there are a ton of who claim to be doctors on there. And sometimes when you hammer down on that, some of them are not truly doctors. Some of them, people use the term doctor, but they may be a doctor of philosophy and English literature and never tell you what kind of doctor they are. Or they're just not well-versed enough to even talk about it in a scientific fashion. Because again, your job is not to twist anyone's arm. Your job is just to educate them. And when they see the education as versus what has been out there, they can see what's going on and understand that what you're talking about is true and is really meant to help them.
That makes me think too that when you first started and talked about Tuskegee, you said this is just one example. And I think the breakdown of trust was a process, right? I mean, it was a repetitive thing that happened over time. And that's kind of what you have with your patients. Like they're talking to you because they trust you more than the guy on TV or the gal on TV. Right. It's a process. It's not going to be one handshake and they trust you.
Right. And especially when you come, that's 40 years worth, right? And I wasn't there when it started, but I definitely remember it. I was born and living during the time, and my family's from that area. So it's something that I heard about a lot. So growing up, I didn't trust doctors, you know, and so it's a process for me to learn how to trust again. So I'm very cognizant when I talk to patients that I need to be patient with them.
Hi, Dr. Baker. I am one of the medical students working with Dr. Irizarry. I have a question. So I'm from Mexico, and a lot of family members, like half of them want the vaccine, half don't, half want to wait, the same kind of situations you were talking about. Is there any specific sources? We kind of have too many sources. So is there any specific sources you would recommend to your patients who are kind of on the fence, or to family members or anybody that you think could be helpful?
Yeah, my first thing is asking why. You know, hey, what is it? What about the vaccine are you afraid of? What are your apprehensions? Because, you know, in order to understand it, you got to see through their lens, right? You can start throwing facts all day at them, but if they're afraid of it for a reason that you're not even touching on, you're not going to even budge it. So just say, hey, listen, what is it? And sometimes they're well-founded. And sometimes, you know, I had a patient the other day said that we're going to implant them with tracker devices. So, you know, I sit down, you know, I try not to laugh, and I literally say, hey, listen, I says, if we're going to put tracker devices in you, there's so many other ways we could do it. We're not going to have the whole country or a whole world giving out vaccines to do that. I mean, we can do it just in a regular visit. So, you know, she says, yeah, it makes sense.
And then I also wanted to ask you, I heard right now when you said that you were doing kind of some forums online for patients and communities. Are those kind of open access, or are you doing them to specific groups, or if somebody who would want to see it be able to?
And we try to advertise it on Facebook, Instagram, on LinkedIn, and Quality Health. Usually all the ones I do are publicized through there. And I've done 3 with Mayo so far. Mayo's reached out and had me join them to talk to the communities, and those were all over 700 people each.
Oh, cool.
So it's been really good avenue for education. I've learned a lot. Because, as I say, this is changing every day, and you know, makes me have to stay on top of it, as well as learn what the patients really need as well. So it's many different avenues, and sure, it's usually open to everybody. So.
Okay, great. Thank you. Thanks.
There's a few questions in the chat trying to hear from an OB. So we have heard a lot in the community about questions. One of the myths that's, there's a few concerns floating around about COVID-19 and pregnancy, COVID-19 and infertility. So we'd love if you can comment on that. And I think Debbie's asking more generally, how do you talk about vaccines to your patients as an OB?
So I do have my slideshow, which I go through if needed, but usually I just talk the way I talk to you guys. I talk about what the mRNA vaccine is, what it does, and I try not to get too detailed because, as we all remember, this is a 6-month course that we took in med school or you know, or back in college when we were studying. So it's not something you can easily explain, but you just try to bring it down to lay terms. If there's videos you can find online, just to show the process of how things work. And as an OB, so I don't see OB patients anymore. But I still consult OBs. I still have patients who come to me who are either either diagnosed as pregnant or are in the reproductive age group and are worried about vaccines and fertility. There's nothing that we know about this vaccine would even hint at affecting fertility in females. So there's nothing, you know, if this was a live virus vaccine, that'd be one thing, but this is not even a virus that we're giving. We're giving a message for your own body to make the spike proteins. And that is so specific and so genius that it really, the only side effects that we're seeing are actually those that your own immune system is giving you because you're creating these new antibodies. So that's how I deal with those patients. Was there another part of the question? Oh, I think that was everything. Yeah.
Sorry about that. I know that people are have already asked, are we sharing the slides? And we'll be sure to get Dr. Baker's as well. My computer's being a little bit slow here. We'll be sure to get his as well. And on the slide deck, you'll see a few, let me try and stop sharing and then start again. CDC has a whole lot of resources for all of you to try and make sure, here you are getting your shot. And if there's any of the nurses or MAs who do our TIPS trainings, we do these TIPS trainings with nurses and MAs all summer long. It's a really fun road trip, but Macrina, who immunized you, is our nurse. She's our hired talent, is what she likes to tell the TIPS audience for the TIPS training. So CDC has a ton of resources to help promote this framework, this Vaccinate with Confidence, and we will make sure to share these slides with you. They are saying, a lot of people are asking, are they safe? Which I'm sure that you're hearing from your patients as well. And these slides will just give you a few talking points to talk about safety. Another one that they're hearing a lot, and the studies are showing, or people are asking, were they tested on people like me? And there are a lot of myths and things on social media saying these weren't tested on African Americans, or they weren't, there were no Native Americans in the trials, and things that are not exactly true about who the populations were that volunteered to participate on the trials. So some talking points for that. A lot of people are really worried about side effects. If you take away one thing from anything I've said today, it's say immune response, not side effects. That is something that we are really is very exciting about COVID-19 vaccine, is that we can hopefully transform how we talk about side effects of vaccines, that this is a typical immune response. This is how it shows your body's working. And on my own personal Facebook page, it's been really cool to see all of the doctors and nurses and EMTs that I'm friends with saying, my body's working because I feel really crappy today. So I think that's good. Abigail saying in the chat, she got a call asking if it's true that 80% of those getting the second dose die. Wow, I wonder where that is coming from. No, that's not true, but I wonder where that's coming from. Yeah. And then CDC also has part of that Vaccinate with Confidence strategy is just elements of an effective conversation. And this is just what Dr. Baker said, starting from that place of empathy and understanding. And we know you are so busy and trying to figure out how to log on to a virtual visit, and you're, can't figure out how you're still 15 minutes behind, or you're running through exam rooms, or the mom in exam room 6 brought all 6 of her kids when she only has an appointment for one of them. And we know your days are so crazy, and how hard it must be to stop and take a breath and really listen to the concerns that your patients are having. But the science is pretty clear that that's what's going to start a conversation that ends in a patient being happy with the decision that they made at the end of that discussion. And that's what the goal is. So the goal is to provide them with the education and all of the science and information that you have, but that they make the decision that's best for their family at the end of the day. So we will share these, but I think that it's all what you already said. So we did want to just ask if is there anything else or final thoughts or anybody has? I'm going to, launch. Oh, that was the last poll results. We're not sure if you would want to log back on in a few weeks for another webinar. You can say yes, we won't, our feelings won't be hurt if you say no, But if you say yes, you have to chat in what you would want to talk about. And while we're seeing those results come in, does anybody have any final thoughts? Or I just have to thank Dr. Baker. That was so great to hear you, and really powerful. And I think that was, I hope that everyone, I'm sure everybody else agrees. So thank you.
Well, I was just so glad
Very
to be
much.
here.
Good. Welcome to our Tappy family. Now you're in. Yeah.
Perfect.
Oh, I had ideas going already. I was like, how
Yeah.
can we do more webinars, and how can we get to some of those critical partners that you talked about, and you know, bring them in.
Well, I'm available. You know, my wife, if she hears me say that, she'll probably shoot me. But you know, I think during the past year and the next year ahead, I need to be as available as possible. And even if it's not me talking, you know, I often share my slides with others that they can give and talk as well. So I look forward to any new opportunities to help with that.
No, thank you. I really, you know, I'm a regular person. I'm not a clinician. I'm on this earth to help pediatricians take care of kids and doctors take care of communities. And, you know, Jen and I both just see ourselves as vessels for you to be able to do our public health thing while you do the hard work of seeing patients. But I think that hearing you say, you know, we need the data to drive us. You know, data should drive us. And when we see disparities like this that we have known all along would have happened, right? Before that first case hit last January in Arizona, we knew that it would hit and it would be disparities, and it is an obligation, I think, that we all share. So anything we can do to all support, to support you, you know, to just call us and email us. We're so thankful for everything you all do every day. So thanks for joining us, and good night.
Good night.